All right, we might get started. Is everyone comfortable? All right, welcome to this session. Our theme for this session is equality. My name is Di Wiseman. I'm from Workforce Development in Alfred Psychiatry here, and I'll be hosting this session and introducing our speakers and running some discussion afterwards, which will lead into a broader panel discussion with the whole group later on in the day. The first speaker I'd like you to welcome is Professor Graham Meadows, to my left, to your probable right. He's from Southern Synergy, which sounds a bit like an electricity company but isn't. He's from the School of Psychology and Psychiatry at Monash University, and he's going to be talking to us about equality in access to mental health care. Please make him welcome.
Thanks very much. Let me acknowledge the traditional owners and custodians of this land, elders past and present. I also want to make a brief personal acknowledgement. My father very recently passed away at 89. He was a control engineer with a strong interest in social justice and issues, and he'd have liked this stuff. So I want to just acknowledge an intellectual and philosophical origin, source, and pay respect to that. So, onward with the content. Acknowledgements, other acknowledgements, people who've worked on various aspects of this work: statistician, general practitioner, health economist, another psychiatrist in Sydney. And some things I'm going to talk through is, we're talking generally speaking about diversity and about trying to get resource distribution right. Well, by and large, people live in places, they access services in places. Getting our understanding of where psychiatric disorders occur, where the needs for them occur, is important if we're going to try and get services alignment, because similarly those services need to operate from sites, and so it's important to get those kinds of alignments right. I'm going to talk a bit about one particular the history of one particular attempt here in Victoria to actually get resource distribution for spatial inequities right, and then I'm going to talk about some work that we did on Medicare data sets from the Commonwealth, which looks at that aspect of funding, and essentially this is going to be some of what we're going to reach in terms of a conclusion. There's some considerable misalignments at the moment in relation to what we know about where needs are and where the resources are flowing. And I'm going to talk about this in terms of possible responses and what led to me to be a crash course in some issues in the Australian Constitution, which actually have important effects on what can and cannot be done in this country. So at one point I'm going to cast us back to 1946. I did a big presentation on this to the College of Psychiatrists, and happily found, because I was like, it's nice to go back to a college, is if you're presenting at a college congress, to something that the college says in its own documentation. So it's kind of nice to know that the college ethics do actually charge us as psychiatrists with doing something about this and supporting the promotion of just allocation of health resources for patients with these kind of problems. So it's good that the College of Psychiatrists is at least a name in there. And actually, when I presented some of this stuff, some of which could be seen as quite critical of psychiatry in a number of ways, it got an extremely good reception at the college, which I thought was very heartening. So when we talk about socioeconomic disadvantage, which is something I'm going to talk about quite a bit, it's very much a composite construct. It's not just poverty. It's not just employment. It's very often something that includes notions of social capital, of issues about educational level, status of occupation, and often of disadvantaged minorities, which are often put together into composite indices. And in the Australian Bureau of Statistics, and I'm quite a fan of statistics bodies. I've done a great deal of work with the Australian Bureau of Statistics and Stat Canada and the OPCS in the UK, and I think they do great work. And they create a number of indices of socioeconomic disadvantage, and this is the sort of content of one of them particularly, which we've worked with a lot, which is the Index of Relative Socioeconomic Disadvantage. So different components of this weight in different ways in the index. They all have different compositions. So as you see, it's very much a kind of collective construct of things which represent degrees of disadvantage in either access to resources or in social status or in ability to access services. And so we've used this quite a bit, and some of the initial, and so this first theme, which is about what do we know about where the psychiatric disorders or the people who have those disorders tend to live in Australia? Well, we did some work that back in, when I first arrived in Australia, which is 1993, whenever you were talking about mental health problems in Australia, people would present data on prevalence figures from the United States, from the epidemiological catchment area studies. Through time, one of the things I got involved with very soon after I arrived was the first national survey of mental health and wellbeing, because in 1997 we had a national survey done, which was the first time that anyone had actually nationally surveyed prevalence, needs for care and the like in psychiatric disorders, and I led the team that derived the instrument for consumer side assessment of needs for care in that context. And it was a really good survey, huge, 10,600 people, 80% response rate, and really nicely designed, nice piece of work. And one of the things that we did from it was we looked at the rates of any of the major rates of psychiatric disorder in different quintiles, and you saw that this was the fifths of the population distributed from in effect, the poorest to the richest, most to least disadvantaged. And you saw a fairly steady gradient from about 21% down to about 16% of people who in the past year had a significant mental health problem as diagnosable by DSM-4 with a structured interview. So you've got a distinct, not colossal, but distinct drop there. And this is now going to be the start of a theme of something else. Because then what we then did was we looked at another instrument which is in there, this actually is the 2007 survey, which is another good survey, but not quite as good actually, a bit smaller response rate, longer interview, probably got a bit overcluttered, but still useful data. But so what we actually got again was a trend, although in this one it actually wasn't quite as progressive, but still the case that the more disadvantaged areas have higher prevalence and the least disadvantaged areas have lower. But this one is kind of interesting because what you've got here is a thing called the K10, the Kessler 10. A number of you will be familiar with this. It's a 30-day indicator of mental health, of experience of mental health symptoms. And there's a number of ways that you can get. It's often classified as an indicator of psychological distress, as if that was completely different from symptoms of a disorder. It's not really. A lot of the time, a lot of the symptoms are really depressive in nature. Quite a few of them are anxiety in nature. And one of the ways that you can have a high elevated K10 score is if you've got a psychiatric disorder, such as a major depression or a generalized anxiety disorder or something and so that ilk, and it hasn't been adequately treated and you've not been got into remission. Or it's for otherwise reasons persisted. Now, there's other reasons why you can have a high K10. There can be other kinds of stressors, other kind of responses, adjustment disorders, or things that are not really psychiatric diagnoses, just responses to stresses. But the thing that we thought was kind of interesting about this, which we hadn't looked at before, was that if you look at the gradient that you've got of the high K10 scores, it's a much steeper gradient than you've got of disorders. So you've got a moderate gradient of disorders, but a steeper gradient of the K10 scores. And the K10 scores reflect a 30-day symptomatology. So what we also then looked at was the proportion of people who had one of these disorders in the different quintiles who still had, at the time they were surveyed, the high or very high distress on the K10. And as you see, that's very appreciably higher among the more disadvantaged quintiles. So what you're actually so one of the things that we seem to be looking at here is that if you've got if in the last year you have significant symptoms of a psychiatric disorder in a poorer quintile, you're much more likely at the time that you surveyed still to have significant symptoms in the form of an elevated K10. So we're starting to see something that's pointing in the direction not only of a higher rate of those disorders in more disadvantaged areas, but also the people with those disorders perhaps don't seem to be doing so well. And we've just had a look at a much bigger survey which was conducted in 2011 and 2012, which didn't include the city diagnosis, but it did again include the K10s, and again you've got this steeper kind of gradient. So this seems to be coming out of a number of available data sets. So what we have then in terms of what we know, and this is concentrating on metropolitan on distributions by socioeconomic disadvantage. I will talk a bit about rurality, but in a sense that there's a bit of a concentration in this talk about that composite construct of socioeconomic disadvantage. So what we've got is somewhat of an increase, about a 30% excess of psychiatric disorders in the last year in poorer areas, as in most socioeconomic quintiles, but a much steeper rate of increase with socioeconomic disadvantage of the K10 scores, which reflect recent symptoms, and also that very high rate of people with 1-year disorders in the most disadvantaged quintiles who still have high K10s. So I'm going to introduce you to a number of great philosophers of the last century. In the course of this, I'm going to begin with the singer, movie star, and surprisingly great social activist, Eartha Kitt, who in a sense perhaps summarised some of what we've just gone before. I've been rich and I've been poor, and I can tell you, honey, rich is better. So it does seem that in a number of ways, the people who are better off and in better areas in better areas of the country are doing a bit better. She will be another company later in the presentation with Eleanor Roosevelt and John Rawls. We'll come to them. So there's a question then about where some of the so that's something about where, in a sense, the level of needs are and where some levels of distress are in Australia. So let's now look a bit about where some of the spending is going and how some of that's been orchestrated and directed through time. And I'm going to start off. This is from the National Mental Health Report, which is a great repository of content on national services here in Australia. And I'm going to start off by looking at so this is the national spend on mental health, big pie on the left, looking at the state and territory government expenditure versus the Australian government and private, and the big chunk then at state and territory government expenditure. Now, I arrived here in Victoria in 1993 from London. I've been working with Graham Thorncroft, Geraldine Strathdy, a bunch of other people at the Institute of Psychiatry in London. And over the course of my time in the UK, I've been heavily influenced by this gentleman, a guy called Brian Jarman. Brian Jarman, not an engineer, actually a geophysicist by original background, who got into healthcare and healthcare planning, and developed a thing called the Jarman Index. And at the time that I was doing training in the UK in psychiatry, which was the late 80s, early 90s, every psychiatrist in the UK would have, typically speaking, adult psychiatrists particularly, would have a catchment area, and they would have known at least two things about their area. They would have known the raw population, and they would have known the Jarman adjusted population. Because there was a simple index, well, it wasn't a simple index, a composite of all kinds of things, but that was used to estimate the needs in populations, and it really adjusted needs from around about 50% of the actual number of people to around about 150%. So you could have a really affluent catchment area, which might have a total population of 100,000 and an adjusted population of 57,000. And you could have a really poor catchment area, which might have a population size of 60,000 and an adjusted population and an adjusted population of 92,000. And every psychiatrist who worked in community services would have known those figures, would have had and they were regularly used as ways of distributing resources, organising catchment areas. And so in the early 1990s in Victoria was an extraordinary time. It was a really revolutionary time in Victoria for the restructuring of mental health services. A quote that I'm fond of from Harvey Whiteford, who was in the State Department at the time, now in Queensland, about the pace of change in Victoria at the time was, it's hard to change anything radically unless you live in Victoria. Because at the time, things in Victoria were changing very radically. It was a very interesting combination, I think, of elements. There was this very strong, very clear, Labour-driven policy about how services should be reconfigured, and some clear structural goals enshrined in the National Mental Health Policy from 1993 and the first National Mental Health Plan. And then you had the the Kennett government, which was completely unafraid of obstacles like unions or workforce or anything like that, in implementing it. So you had this. So in contrast to some other states which had the same background and maybe some of the same aspirations, but actually had left-of-centre administrations, I think the combination of the left-of-centre federal government with a strong, bold right-of-centre federal state government led to an interesting ability to actually push things forward here. Plus some very shrewd moves by some then health secretaries, John Patterson at the time, extraordinary, provocative and sometimes outrageous figure, but really knew how to get things done. Jennifer Williams, stateside manager. So some really good people in a really good policy environment really got a lot of things moving. And one of the things that was going on at that time was that there was this really big structural move from mental health services in the institutions out into community settings. Now that's a really good time when you can use and put something like a Jarman index in place, something that says, right, let's take a view of the populations and let's think about what we can estimate about needs in populations and how we can flow resources into those populations. And so I got involved at a very early point. Philip Burgess, Peter MacDonald, a whole bunch of people were involved in the development of a statewide resource distribution formula, which became the way that resources were distributed out in the course of that really strong period of where what was going on for all the community services across the state was massive expansion. You know, the resources were being taken out of the big hospitals. Around about the time I arrived in Victoria, the Mont Park Larundel complex, just that one hospital complex, used up 49% of the Victorian mental health budget, let alone Ararat, Royal Park, the others. So the community services, you know, within 5 or 7 years, more than 50% of the budget was out in the community. So it was really cataclysmic change. And yeah, some extremely shrewd. It was also very much facilitated by the federal funding through the first National Mental Health Plan, which of course, well, I don't know about of course, it actually funded the CAT teams for the first couple of years, which meant that you could aggressively get on with downsizing the inpatient units without having to fund these new 24-hour services, which then actually could pick up a lot of the troubleshooting if things didn't go all that well with people who were recently deinstitutionalised. Plus other shrewd things like the CAT teams also created very large numbers of high-funded nursing positions, which meant that rather than doggedly digging in as they did in many other jurisdictions and resist the hospital closures, the high-placed nurses all went out and worked in the CAT teams, so they became advocates for the community services rather than sources of resistance. So around about that time too, this is just little thoughts about what was going on. What we had then was that there was an explicit approach to resource distribution put in place, which went through a number of iterations, but it looked something like this. Along the x-axis here, along the bottom, you've got the 21 area mental health services, each of 200 to 250,000 around the state, and population. And you actually had a factor. So you had a variable which said, right, how much money are we going to give to the new community services that we're setting up in these places? And it went from a mean of around $1, from about 62 cents in the dollar to about $1.64. So that the most advantaged area, based on greatest disadvantage and some other things that I'm going to talk about, got about 3 times as much money as the other one, which actually was remarkably convergent with the way that the Jarman index worked, but also convergent with a range of other such formulae which had been assessed in international works, such as the Colorado Social Health Survey, which was probably still the best piece of work that's ever been done. So how was this full factor made up? Well, there was a factor that was about population structure, and that was derived from admission rates to the hospitals before the closures. Philip Burgess mainly did this one. It found at the time, for instance, the salient contributor to that was that if you looked at the time, never married males aged 25 to 44, they had 8 times the overall service utilisation of the general population. Probably because within that are a lot of the people who suffer from from schizophrenia with associated high needs for care. There are a number of reasons for thinking that that particular kind of index would function very differently now. People get married later, and there may be other variables at play, but that was what went into that one. There was quite a strong contributor that was about socioeconomic disadvantage from the Index of Relative Socioeconomic Disadvantage at the time. There were then other factors for people from non-English speaking backgrounds and from private sector. And these are ranked in order of kind of decreasing size, but there actually are a range. There's a set of ways of thinking about these conceptually, which are that you can think about factors that may involve actually something that you think is necessary to adjust the population. If you actually think, as people did at the time, that there was probably under enumeration, for instance, of people from Aboriginal backgrounds, then you may want to tweak the population. Then you have things which affect estimates of rates of need for psychiatric disorder in a particular community, and then you have things that affect cost of delivery. And these, in a sense, come in, and then you can also say, and here's the private sector one, there may then be things that discount if you've got higher levels of substitutive activity. So the formula as it was introduced did actually take a little bit of money off areas that had very high rates of private sector activity. And then there were some other factors for Aboriginal populations, which was about correcting the population, homeless populations as being high need and rurality for increased costs of delivery, which made up this whole sort of spaghetti type thing, but actually was really important in getting the resources out where they needed to be. And I think it was actually critical in meaning that creating the possibility for the implementation of framework, which was a fairly standardized model across the state, because it's very difficult to implement a standardized model if you have a situation where the proportional resources that are available in relation to community need are wildly different. And you can get a good sense of that if you ever get Roger Gurr from Blacktown in the same room as Alan Rosen, who worked most of his time in North Ryde, because New South Wales has not done this kind of redistribution. Things are still very skewed there. So that's a bit about how state funding was distributed in those times. But that's, of course, not by no means all of the funding. We can also look at the Medicare benefits schedule, and we've done some work on that. Now this was actually courtesy of the format of Roger Gurr, because I've for a long time been talking about been trying to get Medicare data on the Better Access Initiative. I've been really interested in seeing whether or not the concern that this fee for item of service approach to funding would lead to inequity was actually valid or not. And I'd had a go at writing to Medicare, and I'd basically been booted up to the Department of Health, and I'd written a few more letters, and in the end I'd given up. Roger's much more tenacious than I have, and has some good legal friends in an organisation called the Public Interest Advocacy Centre in Sydney. And so they went through a whole freedom of information process, and finally, after 2 years, prized out a data set from Medicare of 25 million items of the entire Better Access Initiative and every mental health item from over 4 years, broken down by frequency of occurrence according to postcodes. Roger got the data, but he didn't have anyone who knew how to analyse it. We had a corridor conversation at Themes one year in which I was saying, look, I'd love to get hold of this data, and he said, I've got it. And he sent it to me on a CD. And we've analysed it. Didn't need ethics community approval because it was all freedom of information. There was a lot of data, and a lot of what it showed was that through the course of time, as you might expect with this relatively new introduced initiative, many items went up, except the psychiatry items, which hadn't really been part of Better Access, stayed fairly stable. We published this, and we published it in the Medical Journal of Australia with what for the relatively subdued standards of academia as a provocative title, Better Access to Mental Health Care and the Failure of the Medicare Principle of Universality. We did some collaborative work with The Guardian, thanks to our publicity people, and The Guardian produced a really nice interactive map, which enables you to go and hover your mouse over any local government area in Australia and find out what the rates are. So this is Yarra, where I live, which has, probably based on the kind of material I presented earlier, relatively low needs for psychiatrist services, and it has 277 per 1,000 population items. This is Greater Dandenong, where I work, which by any lights and by the kind of findings that I was talking about has higher needs, which in terms of psychiatrist services has 80. CF Yarra's 277. There's also quite a big gap with the Better Access Initiative, and as you might also expect, though not the main subject of this talk, if you look at the rural and remote areas, it's really even worse. I mean, to give you a sense, the grey areas, there's no data. That is to say, there is no postcode in those areas where any Medicare item has more than 19 occurrences in a year. Not one for any item. So once you get out to really seriously remote Australia, these items they're just not existing. And that's illustrated by this in terms of the different rates for psychiatrists and items. GPs items not quite so inequitable, still dropping down, but not quite so inequitable. And then you have that this was one of these indicators of socioeconomic disadvantage, looking in metropolitan areas and finding that, you've got 2 to 3 times greater activity in private psychiatry in the most advantaged quintile versus the rest. You don't have as big a disparity in the GP items, but on the other hand, nor do you have the kind of increase that you really should be seeing if you were properly seeing equity and proportionality, where you should be getting more of the services driven into the poorer areas in alignment with the kind of way that from 95 to 97 things were done in Victoria, where you can because you got block funding. This is a kind of neat thing called a concentration curve, if you're sort of nerdish, and statistical, in that it takes this idea, it actually plots cumulative frequency of the population by cumulative frequency of services, and this is for one of the key psychiatry item, showing that actually in the bottom 20% of the population only have about 10% of the services, and the top 20% of the population have about 30% of the services. The neat thing about it is that it then reduces it to just one number, because the concentration index is the area inside that kind of banana. And so that actually reduces the whole construct of equity down to one number, as long as the curve doesn't wiggle around across the equity line, which is a bit curly. And so we plotted these. These are all in the MJA paper, which is open access. So you can just Google Better Access to Mental Health Care Failure Universality. That'll find you straight away to the MJA paper. If you go to our website, which is Southern Synergy at Monash, we've got a direct link to the map, which is, as I said, kind of cute. You can go through the particular items, and the paper's got them in economics. In the concentration index, generally speaking, a level of 0.2 is seen as very high, and it's the level that would be associated with the top half of the population having double the services at the bottom half. So it's kind of traditionally regarded as a very high level. And essentially what you get with this is you get a kind of different picture in as much as the psychiatry items are really strongly inequitable. This has pruned out any items with less than $250,000. Clinical psychology also inequitable, but not quite so much. General psychologists, not too bad. General practitioners, not too bad. And so, it varies. But to bring us back, having done enough of kit, Eleanor Roosevelt. So how do we interpret this in terms of justice? This was an extract from the International Declaration of Human Rights, 1948, and Eleanor Roosevelt declaring healthcare as Eleanor Roosevelt holding it had a lot to do with the development of it, and its declaration of health as a universal human right. You can also take an approach to justice which owes a lot to the philosopher John Rawls, which carries an idea that you should construct principles of social policy and of justice as if behind a veil of ignorance, which is to say that you make judgments without any foreknowledge of where you might personally be positioned in society. And this tends to lead to judgments that favour, if any, in any direction, the people who are least well off. And so with that construct, you can actually take a look from a slightly less nerdy approach than the concentration index. You can take a look at at some of these figures, at least for Medicare. And so this is a sort of an estimate of the proportion of people with high or very high K10 scores, using that as an indicator of need, and this would be the rate of psychiatrist items. So what you would expect if you were looking at something that was a reasonable, proportional, equitable distribution in response to need would be something like that. What you get is that. If you were looking at, generally speaking, as in line with Kit's statement, I've been rich and I've been poor and I can tell you how to be rich is better. By and large, the data suggests that people with higher incomes have less in the way of psychiatric problems overall, typically on average, than people with lower incomes. So you might expect that this would be how that would unfold in the population. What you actually get is that. And then similarly, education in some measure is protective against many psychiatric disorders. So you might expect something like that. What you actually get is that. So really things are not very well aligned at the moment. A number of people commented on the material that on the paper that we did for the NJA and the subsequent media. And there was a bit of media buzz about that. So sort of some of the usual suspects got contacted for making comments. I'm just going to, and there's a question here though, and I'll just bring us on to the little crash course that this led to for me in relation to the Constitution. Maybe, I don't know how much constitutional history is taught in Australian schools. Fairly obviously, I'm not originally Australian. I come from the United Kingdom. And so I wasn't aware of this. But in 1946, when the then Labour government was trying to push through the amendments to the Constitution that would give the federal government greater authority to promote things like pensions for people returning for the war, to promote widows' benefits, to promote healthcare, they knew that of course, referendums to change the Constitution have a very poor track record of getting through in Australia unless they have bipartisan support. So in return for bipartisan support, you had this gentleman. Who's this? Yeah, Robert Menzies, who insisted that this set of parentheses be put in return for bipartisan support. And that's why Australia can never have a federal NHS, because it would be deemed as civil conscription. And it's one of the things that actually gets in the way of some of the changes that could otherwise be made to Medicare, like potentially forcing people, because potentially if you really wanted to sort Medicare out, it seems to me it's not that tricky. It would involve a certain amount of money. You say, right, we're going to give everybody schedule fee. We're going to make co-payments illegal, so everybody has to be bulk billed. That's the same as Canada, and you would then restrict provider numbers. You could sort out the inequities fairly quickly, but it's probably constitutionally impossible. So that is a bit of a Cook's tour of kind of about 20 years of work concentrating on these aspects of ethics and connection with different levels of policy and some different data sets, both in Victoria and nationally.
Thank you, Graham, for your very in-depth presentation of your study. It's very interesting for all of us. We have a few minutes for discussion and questions. And just to let you know, after our next speaker, I will provide you all with some post-it notes for you to write any extra questions and questions you'd like the panel this afternoon to consider. So you will have extra opportunity to have input. But we do have time for perhaps a couple of questions now for Graham. They don't have to be statistical in nature. You can ask anything about the study that you'd like. Yes. Do you need the microphone?
No, talking about Medicare, what about Medicare Private? Did you look into that as well? You know, like private healthcare.
No, we didn't. We didn't have the data sets. The data set that we've got was Medicare. If you go back the overall private health insurance spend, particularly on community services, which is what we were particularly looking at, of course, is very small proportionally compared to either the state or the public mental health service facility or the Medicare funding. But it is a very, it's an interesting point. One of the things about it, of course, is that the way that the private system works is just so different because they're really the main way that they can inject additional resources intensively into people is through inpatient admissions. They by and large have less in the way of options for intensive community delivery. It's not entirely exclusive, but so people tend to get much more kind of, in a sense, the way the care is delivered is very different. But no, we didn't. We don't have the data set. I'd be very surprised if it was not. I'd be very surprised, other than that, if we were able to look at it, we found that the positions, that the issues of inequity would be even more extreme with things that rely on pure private health insurance.
Yes.
Graham, you're focusing there mostly on Commonwealth funding, but your original pie graph showed the majority of funding on mental health was from state governments. I was wondering, to what extent have you done any work on the distribution of state funding for mental health, and in particular with the lower prevalence, high intensity mental illness?
Yeah, well, in a sense, the first part of the presentation talked about the way that was designed forward in Victoria during the mid-1990s. And I think that was an outstanding piece of work and probably has laid a really good foundation such that you, across the state, you still probably have, and we've had some access to some data sets on this that indicate that there is still some, that there's still a legacy of that. But I think it is unfortunate that transparent approach to funding has got lost and is no longer so clear. So it's not as easy to tell, and I think there isn't isn't quite the same kind of accountability that existed briefly and exceptionally in that period. The issue of, I think that there's a real question about exactly what the distribution of the low prevalence, high intensity disorders is. We don't exactly know. The national surveys didn't really cover those, weren't designed to pick up spatial distributions, and the low prevalence surveys that were done on catchment areas not intended to give representative figures. So in actual fact, as a scientist, the answer to the question, what do we know about the distribution in Australia of the low prevalence, high intensity disorders, has to be not much. We know something about their overall frequency, and particularly the frequency of people in contact with services, but what do we know about how that is differently distributed? Not a lot. It's actually a problem it's a problem internationally, because most of the work that was done on this was done 20 or more years ago, when you still had the institutional services set up. In that point, because anyone with those needs for care goes into the institutions, you can look at the spatial distribution of the disorders based on where people are admitted from to those institutions. And actually, that was nailed by Ferris and Dunham in Chicago in 1939, and all the work that's been done in that just duplicated their work, which was neat. They did maps, and ever since we went to catchment areas, and so everybody, and most of the world has done this, most of the developed world at least, where you've got defined areas that have capped budgets. If you look at activity levels, all you're getting is a signal of the supply side limitation of the existing budget. So all you're getting is the signal back to you of how much money you put into that area. It doesn't tell you anything about prevalence. So you can't look at the activity data sets. And much of the last 2-3 decades in psychiatric epidemiology have been concentrated on large community surveys, household surveys particularly, whole World Mental Health Survey program, and as ways to enumerate the high intensity, low prevalence disorders. Those are lousy. They don't work because you have, if you look at the National Survey of Mental Health and Wellbeing, which was intended to give you reasonable estimates of disorder prevalence down to about 1%, national evidence, that needed to be 10,000 in size. If you wanted to get subgroup estimates of different parts of the population for disorders with prevalences down to maybe 0.3%, in order to get the subgroup estimates, you'd need to multiply the sample size by about 5, and in order to get the greater precision for the lower prevalence, you'd need to multiply it by about 5 again, and you end up with a survey size of a couple 100,000, and no one's ever going to do it. Sorry? Or the census. Yep. I mean, I think it is a really pressing need, and I actually think there was, we've had these 2 surveys in 97 and 2007. I think if we ever went back into the field, I don't think we should be so interested in getting definitive national absolute prevalence figures. I think if we ever commissioned, I would like to see that if governments ever commissioned that, what they would chase would be the signal about variability, because I actually think that's more important for what we need to know now.
All right, I'm afraid we better move on because we have another speaker to fit in, but please keep your question for the panel and we can discuss it then. Can you all please join me once again in thanking Professor Graham Meadows. Thank you, Graham. I'd now like to introduce Paul Smith. Paul Smith is from the Department of Health, Mental Health, Wellbeing and Ageing. Would you prefer that roving or that? Please make Paul welcome.
Thanks. Yeah, I think there's one. Is there one already loaded up? Get some emergency help. Thank you very much. Can I begin by acknowledging that we're meeting on Bunurong land and pay my respects to elders past and present. I also want to acknowledge everybody in the room who has a lived experience of mental illness, because it's your generosity and feedback that is helping, I think, to move us towards a system where we can better guarantee the kind of equality that Minister Foley and Justice Kirby were talking about this morning. This is a different presentation from the one that you just heard, because I'm going to focus a bit more on how it is that we might better work towards the notion of equality and equity in the culture of treatment services. And so we've heard a really fascinating presentation around just the distribution of the challenge, so where it is that people experience particular kinds of mental health problems and how it is that services might be arranged to respond to those. But I'm interested in the question of culture and how it is that we might think differently about the impact of treatment and how we might take a different lens towards better reaching that goal of equality. And I'm going to talk a little bit, is that what I need to do? Yep. About some of the principles that Minister Foley outlined right from the outset about what government's priorities are and how it is that mental health is connected to everything else, including his equality portfolio. But I wanted to start by just a reflection on Michael Kirby. The first time I heard him speak was in 2002 at the Sydney Gay Games, and I just want to tell you that he had a standing ovation that was bigger than that for KD Lang. So that's saying something. And that stuck in my mind a lot, if you can outdo KD. The Victorian Government's vision, as Minister Foley outlined, is to think much more holistically about the person at the centre of our health and human services responses. We are experts at silos. We love a nice silo in government, and we're pretty expert at kind of managing within those. The real challenge for us is how do we think very differently about joined up systems of care. When you heard Minister Foley, the person who introduced him, read out just the list of enormous numbers of portfolios that he has as the Minister for Housing and the Minister for Ageing, the Minister for Disability and so on, he often talks about being not the Minister for any one of those things but for all of it. And his challenge to us has been on how it is that we might better join up all of those disciplines so that we've got a much more holistic response to people who present with really complex needs. And in mental health, of course, we know that it's rare for people just to only have a psychiatric condition with no other presenting challenges in their lives. And so we have to think very differently about the impact of every single person who comes to our service system. We know that in terms of responding to disadvantage, people with mental illnesses have a range of complex issues and are often denied the services that many of us take for granted. And so the fundamental right to access housing and education and employment, and to realise the obligations and privileges of citizenship, are things that we really need to work hard to gain progress in. If we had to think about what equity means in relation to mental health care, it is recognising that people who come with different vulnerabilities and different disadvantages experience all kinds of barriers to participation in healthcare. It's often hard to have the very first conversation about what happened to you that brought you to this service, and what is it that we need to understand about how to make sure you get the treatment to which you're entitled, and that we can work together to realise people's goals for recovery and so on. And those challenges and barriers can be experienced at the individual and systemic level. We'll talk a little bit about that as well. Fundamentally, as you heard Minister Foley say, that our job in being stewards of the mental health system is to be responsive to the needs of all Victorians. So this government's come to office thinking about how to draw all the strands together in a much more complex system, and to put people at the centre of all that we do. And you heard Minister Foley talk a bit about the 10-year mental health plan. That's a chance to have a conversation with all of you about how it is that we could improve that system. The culture of improved equity inside mental health care is a journey. When we created a new Mental Health Act in 2014, we reflected on how poorly served we were by the 30-year-old Act, the Mental Health Act 1986, which in its own time was considered cutting edge. And I'm really confident that in 30 years, when the next Mental Health Act is written, people will look back at the work that my team and I have done and say, what were they thinking? How could they get it so wrong? Because the community conversation will have moved on so far that we will find it hard to recognise the principles that we thought were really cutting edge for 2014 and 2015. And I'm really encouraged by that idea that as the community conversation about rights and equality and participation evolves, so too will our institutions and the legislation that shapes the work that we do. But we should start with a bit of a conversation about what we think equity looks like inside a mental health system. And as I said at the beginning, this is really a conversation about culture inside our services. So all of you in this room know this and have experience of it, I'm sure. When we find a worker, when we're at a point of need and need to access a service, and we find that person who really understands the intrinsic worth of every person who presents at that service, when we know that the workforce responding to a consumer or their family wants to work with and not do things to a consumer, when the starting point for our services is around empathy and compassion and a real interest in the story about that consumer's background and what brought them to our service, rather than making assumptions about people's background or making judgments about the sorts of services to which somebody might be entitled. We have a sense then that people who are our healthcare professionals are engaging with their hearts and their heads. It's really important, I think, that when we think about equity, we think about a culture of service that means that the worker stays with that person, are present with them as they re-establish their sense of balance when they present at a time of trauma and distress. So caring about what's happened to people rather than what's wrong with people is a really important starting point. And many of you know much more than I ever will. I'm not a clinician. So about the importance and role of trauma-informed care, and really understanding a better way to begin to ask questions and establish a dialogue with somebody about what's happened in their lives which has brought them to this place, and how it is that we might think differently about the individual. In order to do that, as I said, it requires really strong leadership in each service. I'm going to talk in a little while about some of the observations I've had in experience with the team at the Alfred and some of the amazing work that they've been doing to reinforce some of these issues as well. So it requires leadership. Thinking about how to deliver care equitably also requires an authorising environment that says that time to care is a really important feature of the way that we deliver care in our service, and a really strong humanistic approach. We can't fix it ourselves inside the mental health system, so one of the things that we are very mindful of is the impact on people's recovery of the interactions that they might have with other parts of the service system. So we've got to work much differently and better to ensure that other parts of the health and human services system have literacy in mental health, have an understanding about what the experience of someone with a lived experience of mental health is, and how it is that that might present challenges or barriers to be overcome in accessing other kinds of care. If you're looking for housing and somebody says, come back and see us when you've got your head sorted out, it's a terrible setback for people to begin to access a most basic right. I had a really interesting case study presented to me by the Minister, who, as you know, because he's your local member, is a very, very active local member. He was describing to me the circumstances of an older woman who was homeless and living in her car. It wasn't that there was a lack of homeless services able to meet her need, but she had a particular phobia, and her phobia was using lifts. She couldn't actually get into a lift, and the housing office was up a lift in a nearby building. So this wasn't it wasn't that there was not an opportunity to be able to engage with this person who had a really demonstrated need. It's that the prerequisite for getting a service was something that she couldn't manage, and she actually needed someone to recognise that there was an intersection with her own mental health problems and the shining beacon of the potential for housing that was inaccessible to her. It's a tiny story, but I think it's an example of how it is that we need to think differently about the literacy of our colleagues in other service systems and their capacity to understand what some of the barriers might be for people accessing their care as well. So those things are really important to think about in getting those right. We've heard from the Minister and from Justice Kirby this morning just about the differential experience of people who have mental health problems and how the experience of trauma can be compounded, particularly for some groups. And people spoke with great eloquence about the fact that not every member of particular groups experiences difficulties or problems, but that there can be some compounded common experiences for people, particularly in relation to discrimination and stigma, that can be shared and represent a challenge for all of us to think differently about how it is that we value the experience of each person who comes to us seeking our care. You know about many of the experiences of groups such as the ones listed on the slide, and how it is that our workforce needs to think differently about people's experience of discrimination, rejection, barriers, and how it is that we might have better conversations. I've been really, really encouraged in my time in working in mental health at the power of consumer and carer voices to shape services differently. It's really important that we continue to provide avenues for robust feedback, that we're not afraid of the feedback and criticism from users of our services who can teach us a different way to respond to some of the experiences people have had in the past. Just to take one example, the experience of some women in our mental health inpatient units. Without a really strong focus on the recognition of trauma that many people have been through, including issues like family violence or child sexual abuse and so on, we'll never get to a really deep understanding about how it is that people's recovery can be put back on track because we keep on carelessly through perhaps a lack of thought and a lack of recognition of the trauma that someone has been through, risking creating environments where people don't feel safe. We've had, in the last couple of years, really strong and impressive feedback that has been consumer-driven from our peak bodies who have talked to us about the experiences of women in inpatient units and the need for us to think differently about safety, about recognising trauma, how it is that we might construct a different physical environment, a welcoming, safe and friendly environment, and not expose people to the risk of being re-traumatised and so on. That powerful consumer feedback has been critical in thinking about developments like women's only lounges and a range of other things that we can do differently to respond to that trauma as well. And we have examples for each of those groups, as you know. The new Mental Health Act did represent last year a really significant cultural change in the way that we think about the rights of consumers to be present in every part of decision making about their treatment and care. But it still sets apart the clinical services and recognises that they have significant powers. The power to compel involuntary treatment is a really significant infringement upon people's rights and needs to be managed in the least restrictive way for the shortest duration possible. That represents a really fundamental shift in power, but with power that still is retained by our clinicians comes some real responsibilities. So the Act says that restrictions must be justifiable, proportionate and include effective oversight and safeguards. And so if we are thinking about what that means in terms of equity, it means protecting the rights and responsibilities for every individual consumer and understanding how their own experience of something like involuntary treatment is deeply personal and requires a differentiated response for each person who comes into our care. We've got a number of oversight bodies that are new in Victoria that are mandated under the legislation, and when they work together and when they come to full strength, there'll be important safeguards for the rights of individuals and consumers. And one of the important things that we've established as a mental health tribunal as a quasi-judicial body, and it makes treatment orders for patients, but it also requires that the recommendations made by treating teams are compliant with the legislation. And so there's a real opportunity for the Mental Health Tribunal to be establishing a much more collaborative treatment relationship through the treating psychiatrist with its focus on recovery. And so it means that the authorised psychiatrist and other members of the treating team are free to engage with the patient in ways that promote recovery-oriented mental health care because of the separation of the tribunal's role. One of the most important things that's happened is the establishment of a Mental Health Complaints Commissioner. And it's early days in the life of this new role. Why I think it matters in terms of equity is because we are getting a really strong sense from the independent work of that commissioner in responding to complaints and questions from consumers and carers about how they felt about the care that they had and what some of the challenges are that remain in the way that we engage with consumers and carers in our treatment system. And what that means is that we're getting a better understanding of the gap between what we think we are doing as clinicians and treating teams and how that care is actually experienced by consumers. So I just wanted to quickly touch on some of the early learnings from the role of the Mental Health Complaints Commissioner, because it can help us understand the gap between what we think is being delivered or what we intend and how people are actually experiencing care. And there are a couple of really interesting issues that consumers have raised with us that get back to the heart of the challenge of culture and how, if we are truly to be able to demonstrate equality in the way that we deliver care, we'll need to pay more attention to some of the conversations that we have, to some of the responsibilities we have to set the context for people to understand how decisions are being made about their lives. So I want to just talk quickly a bit about some of those things too. It's early, as I said, in the life of the Mental Health Complaints Commissioner. She's been in post for just a bit more than a year, and we've had more than 1,000 inquiries and complaints. And you can see the split between those. Most of the issues are around compulsory treatment. Why am I here? I don't want to be here. It hasn't been explained to me adequately about why I'm in this service. And issues around the need for improved communication. So we know that those things are really key to people's sense that they have been treated justly and that we have accommodated people's needs in responding to diversity and so on. So there have been themes around the wishes and preferences that people have in relation to treatment, a focus on the least restrictive options, and the need for us to lift our game in relation to communication. And there have been issues around access and so on as well we talk about. But I wanted just to highlight a couple of enduring themes that are probably very familiar to you if you work in a service or you've been a consumer in a service or you are a carer for someone who's recently had a time inside an inpatient setting. We get a lot of feedback around communication, both the style of communication and also what's actually being said. If we are to deliver services that reinforce a culture of equity, then it's really important that we assure ourselves that the message has been heard in whatever way is required for that to be able to be understood by people who might be in varying levels of distress and so on. So most of our complaints are from compulsory patients. They often say they don't know why they're an involuntary patient. I feel like they haven't had their rights explained. Even if we think that that's occurred, it's only really effective if people understand and can support the idea that the feedback that we've been providing has been adequate. Each complainant to the Mental Health Complaints Commissioner has the chance to discuss their circumstances, and they're supported to make some decisions about what they want to do in the short term. And importantly, the Mental Health Complaints Commissioner is establishing a really robust and supportive relationship with each of our area mental health services. It's very important that those services get the feedback that's been independently provided so that they can reflect on it and think differently about how to respond to their own very feedback. It's very exciting. The staff of the Commission have been delighted at the responsiveness of services, their willingness to listen to feedback and to respond to suggestions that there are better ways and different ways to ensure that our communication challenge is heard. The second theme is one that's been a bit of a perennial, and we kind of know it a bit instinctively. It's about how it is that we communicate. We know that staff are really busy and stretched, and that some consumers have particular demands that feel that they are hard to meet inside service settings. But the common experiences that we can focus on and that I know teams are wanting to do differently and better is that issue around spending time with patients and communicating in a way that doesn't feel dismissive. So we get quite a number of pieces of feedback that says busy units don't leave enough time for individual support and care. It's frustrating for staff who want to do their very best to assist people to focus on building the rapport that makes a focus on recovery journeys possible. But sometimes it's quite hard to get all that right, and so consumers often experience that as being ignored or being curt and dismissive. And the last thing that was a bit of an unexpected one for me to hear about is complaints about access to mobile phones. And if you think about it, one of the things that all of us rely on is our communication with our outside world. We manage lots of parts of our life with our mobile phone. And where people have experienced a kind of blanket ban on the phone, it can be extremely confronting, and it can feel sometimes like the decision has been arbitrary. It might be explained in a way that says this is about everybody's safety, or we've got a blanket rule here that says you won't have access to mobile phones. It's probably not going to be the case in other parts of the health service if patients experience different kinds of care as well. And so it's become common practice for people not to have access to mobile phones in some acute units. The Commissioner's view about this has been that this is a pretty routine part of daily life and an important way for individuals to stay in touch. There may very well be, based on the advice of the treating team, a very sound reason why a particular person will have their recovery compromised if they are being harassed by a caller, or if there are issues in relation to the use of that phone being a setback in relation to people's clinical treatment. So the real concern is to find alternative ways to deal with their concerns about the use of phones and or cameras, or being on Twitter or Facebook or other things that can be a setback for people, and to make that a discussion that's based on trust and clear boundaries and so on. And so it comes back to a discussion around honouring the experience of every individual, making sure that there's a sound clinical reason for some of the experience of rules and regulations that sit inside a unit, and to be open to the sorts of discussions about what alternatives there might be for that person, so that we are, if we are supporting a culture of engagement that is about equality, that we've got a sound reason for a decision that we might take in relation to every individual patient, rather than the fallback of a kind of blanket ban on some things. So that's a little bit of feedback just from the Mental Health Complaints Commissioner, all of which is helping us to think differently about how it is that we might work to better guarantee responsiveness to the very individual needs we experience in an inpatient unit at any one time. I said to you I wanted to reflect a little bit on what the Alfred has been doing, and I'm glad that Steve's just walked into the room because one of the really fantastic things that the Alfred has done recently is to participate in an exercise along with some other area mental health services to test a model called Safe Wards, which for those of you who are not quite so familiar with it, is a way of reflecting on the culture of service delivery inside an inpatient unit and to do our collective best to de-escalate issues around tension and stresses for patients and for staff, and to find a different way for engagement with people that can have a much stronger therapeutic underpinning and reduce some of the risks of unacceptable behaviour, the risks of occupational violence, the risks of a spell in an inpatient unit being a testing time for people rather than really focused on people's recovery. And so one of the most exciting things for me to hear about has been the way that services themselves have really led a reflection on the culture of their inpatient units, and revisiting with all of the members of staff in that team, whether we're talking nurses or allied health workers or medical staff or cleaners or others who might have an interaction with patients, on how it is that we might structure the way that we interact in order to reflect some principles that are really at the heart of decent care. And they include things like telling stories about ourselves, finding out more about patients and their backgrounds, encouraging patients to disclose information that speaks to their interests as a human and allows staff to share a bit of their own story about what it is that they are interested in order to present a human face to patients who are currently in the inpatient unit. That's so important because it builds the sort of rapport that demonstrates from an equality perspective that every single story matters, that every life matters, that we have an interest in people's backgrounds, that we are focusing on people's personal journeys, and that we're humanising the environment. With that level of engagement, which the Alfred has been demonstrating and working through, issues like stress in the unit can be minimised, and people can spend their precious time focusing on the things that really matter, which is encouraging people with their journeys of recovery and so on. And it can be an intervention that has a preventative dividend. It prevents the escalation of antisocial behaviour and crisis. And what it means is that we are listening really closely to the feedback from patients and carers that says the experience of care is as important as the outcome of care. And at its heart, the thing that has most encouraged me is that people have said to me, it's been a reminder for me about why I came to work in this profession in the first instance. I've said before that I've never met a psychiatric nurse who joined that profession in order to seclude somebody. They really wanted to be a part of someone's recovery journey and to experience the joy of working with someone to return them to positive mental health. It sometimes feels that that's hard to do in an environment where we are busy and under pressure. So the work that Alfred's been doing through Safe Wards is a good example. It's not the only one, but it's a really good example of that cultural change, which is supporting consumers and families to feel better about their experience of care, and for staff to be much more motivated to deliver the care that they have been. As we just heard from Graham, there are some really challenging systemic issues for us to focus on, and one of those is the funding model. So at the minute we are focused on inputs rather than activities, and we've got a long history of funding in particular ways, and part of our challenge is about how we think differently about the way that acute mental health care is funded. We are funded in particular ways. We've also got boundaries around how we deliver care, so there are very tight catchments. People don't get to exercise choice in the way that they do for any other part of their health care, and these are issues that are top of mind for us as we think about our 10-year mental health plan and how we might do that more effectively. It's very hard to tell a story about encouraging equality and equity of access if we've got constraints around where people can seek care and get and exercise choice as consumers. we do have a messy mix of state and Commonwealth programs. Wouldn't it be wonderful if we could think about a seamless approach to navigating the mental health system so that consumers and carers didn't have to be exercised about who was funding the service, but that the service matrix clicked in seamlessly around them. So it's not always easy for people to access the right service at the right time, and that's the focus we want to build on. Finally, we are really to think about improving equity and equality in our approach to healthcare. It really comes down to focusing on choice and holding ourselves to account for the quality of our care so that when people can make choices, they're able to do that as full citizens. We are focusing on some particular challenges through our 10-year mental health plan. That's the subject of discussion with all of you just at the moment. We want to focus on diagnosis and risk and ensure that we have the best menu available of supports for people with complex needs. And as I said at the beginning, and the Minister also mentioned, one of the most important changes we want to see over time is much more literacy in trauma-informed care. Many services have really been championing this as at the core of their focus on people's recovery. And it will come down to the training of the workforce, our capacity to engage differently, hearing the stories from consumers and carers about their experience of care, and so that we are better able to ask the question, what's happened to you, as opposed to what's wrong with you, so that we think about people's history rather than just their medication needs. We need to also understand that our service system exists inside a range of other complex community needs and challenges, and to understand how it is that we can get the balance right between looking after people who've experienced mental illness and engage the community in a much more respectful and mature debate around mental health and stigma. So we often have, as all of you know, a skewed community view about safety in relation to mental illness, and we need to change that paradigm and work differently around that as well, and have human rights at the centre of all that we do. Just finally, I wanted to finish where the Minister began, which is around our chance to think very differently about equality in mental health provision and about the culture of service delivery in our treatment services by rethinking the connections between human rights, our own work, and the parallel systems that need to be better joined up right across health and human services. And in 2015, we will be talking with you about what that 10-year mental health plan will look like, with a much stronger focus on the views of consumers and carers in shaping and co-designing our future care systems, with a legislative framework that promotes much more supported decision-making and has recovery as central to its aims, and thinking differently about some of the huge changes that we will all be caught up in. So the once-in-a-generation change of the National Disability Insurance Scheme as part of the context. So the discussion that we will have with you is one about testing priority areas and where to begin on this journey to better guaranteeing a much more equitable approach to the provision of care in mental health. Thanks.
Thank you, Paul. We have time for a couple of questions. Yes, Julian. Julian.
I'm really impressed with the use of compassion now. And I think that's something to be commended, that services should start with compassion.
I was really encouraged at the feedback that I had from staff themselves who had, I think, got back in touch with why they became nurses and allied health workers in the first instance, and had felt, I think, in pressured, busy lives, no one's underestimating how challenging the work is, to have lost sight of some of the reasons why that mattered. And so the work that happened at the Alfred and in other places was a chance to revisit the culture of service delivery and to start with valuing every life. So telling stories about yourselves as a team of staff, hearing about individual consumers' backgrounds and stories, the things that they wanted to share, enabled just a much more human dimension to their care right from the outset. I think that's to be applauded.
I have one concern on the counterbalancing of it. As we know from the work of Meadows, a geneticist, and Tanya Singer, a neurophysiologist, that other compassion leads to burnout. What are we going to do, though, to counterbalance so that the staff are able to self-care, have self-compassion, which is something alien in our society?
Yeah, I think that's right. I think that there is an enormous investment we need to make in helping people to manage the stresses of their work. And there's a lot of work now happening, I think, in teams to recognise that. So as an employer, health services have obligations to their staff. We also have to think about the kinds of processes that are undertaken in jobs to free ourselves from some of the constraints that prevent us from doing the work in the way that we would like. I was amazed when I did I was talking to a service in the northern suburbs a little while ago when they had, on their own initiative, done some survey work about how much time each staff member spent doing particular kinds of work, including time spent with patients. In that service, at that time during that survey period, the occupational group that spent the least time with patients was nurses. The group that spent the most time was cleaners. And I was really intrigued about what it was about the work that nurses felt compelled to do, distractions about paperwork, all of those kind of things which are important, which were preventing them from doing what they most wanted to do. So part of the solution is really good kind of regrouping around what it is that we are spending our time doing, what are the administrative burdens that each occupational group has, how can we do some of that stuff a little bit differently and carefully so that we're not duplicating it and we're not making time spent with patients the most expendable part of the job. Yeah.
Hi, Lynn Carpenter from Frankston Aged Inpatient Unit. I haven't heard the word dementia mentioned once today so far, and as a nurse on the peninsula where there is a very large aged population and we are seeing more and more patients admitted with advanced stages of dementia and their BPSD, and I'm acutely aware of the impact that this is having on our service and the other patients with other mental health issues on the ward. There is a huge amount of staff burnout as a result because we are not getting to spend any time with the other patients. And I'm just wondering where this fits into the grand plan and are there plans to address the issue?
There are indeed, and one of the helpful things is having a Minister for Mental Health is also the Minister for Aged Care and Ageing. So those sort of intersections and thinking about what it is that we need to do and think about differently are pretty live. And that's important because this is an area where there will be growing pressure into the future as our population ages, as you know. So the skill set for people, how we value the work that nursing and other staff do in supporting people who've got that mix of mental illnesses and organic conditions and so on will continue to grow, and it's going to be an area of new and important special expertise, I think. So we have to think about the long view in relation to this. What are the workforce requirements that we will have? What are the competencies that people will need to think differently about this? And also, and I think really importantly, are the care settings that we have the right ones? The ones that we imagined 30 years ago are maybe just not fit for purpose in quite the same way now when we think about what people who live for much longer might need, the congregate care settings, the right shape, the right mix, and so on. So you're right to raise it as a concern. I think it is a priority for this government to think differently about it because we'll all be facing it soon enough.
We will. Can I ask you all to join me in once again thanking Paul Smith and Graham Meadows, a small token of appreciation for you both. Enjoy. Now, we have a quick activity for you to complete. I'm an occupational therapist, so I like everyone to do an activity before we go. I can't resist, but you won't have to form a group or hold hands or anything. I will ask you to, we're having a panel this afternoon, a panel discussion, and on that panel will be Radhika, who's a psychiatrist from our transcultural mental health unit. We'll also have Catherine Bennett, who's the consumer consultant here at Alfred Psychiatry, and we'll have Paul Smith. So I'd ask you to have a think about what questions you'd like the panel to consider. We're going to ask, you don't have to contribute a question, but if you've got one, we'd love to hear it. I'd like you to write it down on the sticky note and just pop it up here on the whiteboard for me before you go to lunch. have a think about a broad-ranging question that you want to ask. I also want to give you a reminder about lunch. I'll pass these out as I go. Ask you to take some and pass them on. A reminder that we don't have lunch catered, and it is confusing because there's another lecture theatre over there who does have lunch catered. So the distribution of wealth, once again, does not go to psychiatry, but we won't go there. So I ask you to, it's just a reminder about lunch. You've been informed about, there's a number of cafes. There's 2 cafes on site, and we're in Paran. We're surrounded by cafes. So we are coming back here at 1:15 p.m. for Nazim, who's going to entertain us and talk to us for half an hour. And we'll be back into this room. Okay, so please put some questions on the whiteboard before you go. And if you have more than one, please contribute as many as you like. Someone's looking at me questioningly. Got your USB? We usually end up with a few USBs. Clicker.
That one I think is Paul's.
I'll just check with Paul. Not seeing any stickers on the board. I want to have, but we need some questions. Otherwise, I'll make them up. Oh, well, this is fancy. You all got stick notes and pens? Have pens and sticky notes if you. I'll check. That is the other question about it, like the panel consider. Honda, Kito, I'll leave some sticky notes up here. Thank you very much. No, I'll ask you
Okay.
Thank you very much.